We are live now, doctor.
So, good evening, everyone. I am Dr. Lipi Mittal. I welcome you all on behalf of Team YOSI and Team Cataract Focus Group on the webinar Mastering Capsulorhexis. So, this is going to be a series of webinars on various techniques in cataract surgery. And today is the first of the series, that is Mastering Capsulorhexis. And I would like to thank Dr. Anujit Paul for giving me this idea of the series. So before starting, let me just introduce you to the team YOSI briefly. We have Dr. Devakant Mishra sir as the president, Dr. Sonal Kalia ma'am, immediate past president, Dr. Karan Bhatia sir, vice president, Dr. Nilesh Kumar sir, secretary, Dr. Aditya Sethi sir is the treasurer, Dr. Prasanna sir is the joint secretary, and we have 20 members of executive, 20 members of executive members in the team across the nation. So this is the Cataract Focus YOSI group. Along with me, we have Dr. Aishwarya, Dr. Anup sir, Dr. Mohammad Abrar, Dr. Nishi, and Dr. Soumya. So in the recent past, we had conducted Cataract Chitra competition, CCC, in which various participants across the nation participated in the competition. So for today's webinar, we have our expert panelist. We have Dr. Harshul Tak sir. He is the director of Rawat Eye and Phaco Surgery Center, Jaipur. He is an assistant editor of IJO Cataract Section. He is an executive member of Indian Intraocular Implant and Refractive Society of India. He is also the governing council member of Indian Society of Cornea and Keratorefractive Surgeons. He is the honorary secretary of Rajasthan Ophthalmological Society, also the past secretary of JOS. He has been awarded Chikitsa Bhushan Award by the Health Minister of Rajasthan, and he is also one of the members of ARC Central Zone. We welcome you, sir. We have Dr. Nilesh Kumar sir, who is the medical director at Madhvi Netralaya Ara. He is the innovator behind DIGS and DIGS Pro, and he has bagged various national and state awards. He has more than 96 peer-reviewed published articles and has presented more than 135 papers and invited lectures and live surgeries in various national and international conferences. He is the current secretary of YOSI and ex-joint secretary of YOSI. He is also an executive editor of iQuest, assistant editor in AIOS Dynamic ebook. He has been the chair of communication, Retina Rocks and Retina World Congress, and he is the convener of transfer skill course at AIOC 2021 till now. So we welcome you, sir. So before starting, we would like to have few words of address from Dr. Harshul sir and Dr. Nilesh sir.
A very good evening to all the young ophthalmologist brigade which is there. And thanks a lot, Dr. Nilesh, Dr. Lipi, Dr. Anujit, for giving me this wonderful opportunity to interact with all the young and dynamic surgeons here. And I must congratulate all of you because you all have been doing a wonderful work in promoting the science and brotherhood among fellow young ophthalmologists. And you are taking up this task to make them, more expertise and experience in various skills of ophthalmology. I think you people are doing a great job. We are always there with you whenever you need us. Thank you so much. And looking forward for today's webinar on Capsulorhexis.
Thank you so much, sir. Thank you so much for always being there. I think you are the biggest supporter of our socio-cultural group as well and given us a space in that Life Beyond Ophthalmology group. So thank you for all the encouragement ever. And congratulations to Team Cataract Focus, Dr. Lipi, Dr. Anujit, for bringing out this very necessary topic. I think taking one of the key aspect of surgery at a time that will help residents to get more information and to invite experienced surgeons like Dr. Harsu sir to give their nuggets that will help them to overcome the difficult situation. From governing council, on behalf of governing council, we always are there for you, and we think every team is doing a good job. Last cataract Chitra competition, I think that was a runaway success. I think 300 or some more views at the time of live. That was unheard of in live webinars. So thank you for that. All the best for today's webinar as well.
Thank you so much, sir. So let's proceed. So for this capsule of webinar, we have a resident corner as well, in which Dr. Aditya, who is a junior resident from GNEC Delhi, and Dr. Nikita, who's a junior resident from Gandhi Medical College, are on the hot seats tonight. So they will be giving us the resident's perspective on the Capsulorhexis and will be asking the questions and doubts directly from the speakers and the panelists. So, sorry. So before starting, I would like to ask my co-moderator, Dr. Anup sir, who is also one of the most active members of the Cataract Focus Group, to please introduce our first speaker.
I request all other participants to please mute yourself so that we have an uninterrupted session. Okay, so now going ahead with our speakers, I would like to introduce Dr. Sandeep Chaudhary sir, who had completed his MBBS and MS from PGI Chandigarh and is currently working as cornea refractive and glaucoma services consultant at ASGI Hospital, Jaipur. His area of interest holds cornea refractive and glaucoma surgeries, also including pediatric and adult glaucomas. He has several publications in his name, and he was also awarded the best research paper presentation at the annual conference of UKPGS, that is United Kingdom, International Presentation for the Pediatric Glaucoma Society in 2021 and 2022, and also in Indian Pediatric Glaucoma Society. He was awarded Best Surgical Video in Glaucoma section in AEC Cinefest 2021 and also Roscon 2023. Welcome, sir. I welcome you on board.
Thank you, sir. Thank you for this kind introduction. So can I start sharing my screen now?
Yes, sir.
Yes, sir, please.
Thank you. Thank you. Good evening, everyone. I'll be discussing step-by-step guide to performing Capsulorhexis. So Capsulorhexis has evolved over time from being a primitive technique where tooth forceps was used to grasp and rip out a part of anterior capsule. Just a minute. Okay, so rip out just a part of anterior capsule, and as it sounds, it was a very crude method and a very unpredictable one, used to have ragged edges, and which may have landed up in a complicated scenario. And it evolved over to a Christmas tree approach where we targeted to make kind of a triangular kind of shape for Capsulorhexis. Then eventually canopner technique came where the surgeons used to make a small nicks in the anterior capsule and then join them with the cystotome. And eventually what we see today as continuous circular Capsulorhexis came up in 1985 from Howard Gimbel and Thomas Neuhan. So this is the kind of evolution of the Capsulorhexis. So the question comes, so what's this obsession with this round shape? So why do we want a CCC? So the advantage is that the intraoperative stress, when you have a round continuous Capsulorhexis, it gets distributed evenly onto the equators of the zonule, and the capsule can be stretched with a very low risk of radial tears because there are no sharp angles here, and which makes the surgery also a bit safer while we are doing a hydrodissection and especially the cortical aspiration, because even in canopner technique also, like the small tags of capsule can commit the aspiration while aspirating the cortical matter. And also it also allows a symmetric and safe positioning of IOL in the bag, and if the need be, it also gives a good support for sulcus implantation also. So the aim in cataract surgery should be to achieve a complete circle without any radial tear, a well-centered one, and we aim to target about 0.5 mm field. We want around all of the optic of the IOL, so that it decreases the rate of PCO formation also, because prevents the anterior and posterior capsule uh, uh, creates a layer of separation between the anterior and posterior capsule also. So the centration and size are important. So the process starts with making the ports, and then comes the capsular staining. So why do we need to stain the capsule? Is it mandatory? No, it's not mandatory, but yeah, it increases the visibility. So if you have a good retinal reflex and you don't need, you have a good visibility, then you don't need to stain it. But if you have a cataract kind of cataract which like obscures the visibility or red reflex like white cataract or dense PSC, then in those cases it definitely helps. And especially in pediatric cases where the lens capsule is very elastic. So studies have shown that the staining also increases the stiffness of lens capsule. So lens capsule, we need to understand it's not like a paper, like it's not stiff, it's like a cellophane membrane, and the kind of tear which we want, it becomes more predictable if it's a more kind of stiff, because with stiff paper kind of material, we can predict the movement of the tear which we try to make. But with an elastic material, becomes a bit unpredictable. So the staining process can be very easy. It's very easy. You can inject an air bubble and then just stain the capsule beneath the air bubble, or you can just directly inject the dye into the entire chamber and then wash it off. There are some scenarios where you need to put in the viscoelastic first, like if there is a posterior synecdoche or a polydilating pupil. In those cases, you need to put in the iris hooks first to visualize the anti-capsule or the lens. So in those cases, you can just either you can like put in a air bubble just to displace the viscoelastic a little bit, and then try to stain the anti-capsule, or you can just straight away stain the entire capsule directly, bringing the dye cannula in close vicinity to the capsule and stain it directly and then wash it off. So whatever works for you and whatever the need of case is, but yes, definitely it helps. The staining, it helps. So what are the force factors which are at play while we are making the capsulorhexis? So one which is very apparent one is the extrinsic force which is applied by the surgeon. But what are the invisible forces which are at play? So one is centrifugal force which comes from the zonal fibers, and then the next comes is if we see from the side, so it's interlenticular pressure and vitreal thrust which pushes the anterior lens capsule outwards, which we need to counter with the OVD pressure in the anterior chamber. So these are the four sectors which are at play while making capsulorhexis. And on top of that, there is an elastic nature of capsule, which is also there. So we need to keep in mind all these factors while starting off with the capsulorhexis, and as we are giving it a shape. So all these factors are there. So first is the mechanics of capsulorhexis. The external force which is applied by the surgeon can be of broadly of two kinds. It can be a stretching force or a shearing force, which we will be discussing in the coming videos. So the checklist for a beginner surgeon should be to check if the adequate viscoelastic to flatten the entire capsule and fill in the entire chamber, because this is the most critical part which we discussed here, the pressure. So we want the pressure gradient to be in our favor, because we want the interlenticular the pressure in the anterior chamber higher than the interlenticular pressure, so that the anterior capsule is flattened out. Because if the capsule is flattened out and the pressure in the AC is higher than the interlenticular pressure or the vitreal thrust, then the chances of runout of rhexis are pretty less. So we want to balance the pressure and we want to keep the pressure gradient in our favor. We need good visualization, if the need be, stain it, and also we need a good centration and sizing. For centration, you can keep the Purkinje images as your guiding principle, or for sizing, you can use an optic marker, or there are dynamic markers available with the Callisto kind of thing. So they can show you the rhexis margin of the desired size in the real time. The basic instruments for CCC include cystitome, which is very easy to make, a 26 gauge needle, bend it 90 degree near the bevel, and then bend it to an obtuse angle near the hub of the needle, and you're good to go. So in less than 10 seconds, you can make a good cystome. And then apart from that, you can also use forceps. A variety of forceps are available. Utrata, Haldi, Burger, microaxis forceps, Inamra forceps, whatever works best for you. So we will also see a bit of surgical videos with these instruments. So to begin with, the rhexis with the cystitome, we should always enter into the AC while keeping the cystitome horizontal, and then make it vertical as soon as we enter into the AC, and then start it with making a flap. So what works best is, what I've seen is, if we put in a gentle pressure and put in a gentle tap on at this point of the flap, so right next to the fold, if you put in a gentle pressure over that part of the flap and then pull it with a shear force, and you pull it with the shear force, that works best. So this way you can see that the rhexis movements are well in control. So that's how you can proceed with the cystitome. Basically, every 2 to 3 clock hours, you need to redirect the flap direction, and you need to keep re-grabbing the capsular, the flap edge, and then rotate it. This is the rhexis with the Utrata forceps. So with the Utrata forceps, you can use the initial puncture you can make with the. I prefer to make it with the Utrata forceps itself, but you can make it with the system arm also. With forceps, the need to regrasp the flap margin is less because there are two forces at play. We are also using a shear force, which is when we keep the flap parallel to the anterior lens capsule, and the tear force when we are stretching, we are pulling the flap edge centripetally. So both these forces are at play while using Utrata forceps. So it becomes quicker. It's quicker with Utrata forceps. Also, you can use Haldi Pulka forceps. So, like as I said, you can make an initial puncture with the cystitome and then use a Haldi Pulka forceps. So, if you notice this Haldi Pulka forceps, this is uh, the basic functioning is like Utrata forceps only. But if you see these arms are a bit flatter as compared to the Utrata forceps. So, it gives a better closure of the main port wound. So, the anti-chamber maintenance with the Haldi Pulka forceps is easier as compared to the Utrata forceps. And from my personal experience, once you are used Aldipurco forceps, there's no going back to the Utrata forceps. So for beginner surgeons, I would suggest that if you are the rhexis fan, then you should try with the Aldipurco forceps in at least in the starting part of your journey. Now, the microrhexis forceps. So these forceps are also very useful in some specific cases. Like in this patient, he was a PACG patient and very shallow AC and very thick lens. So I needed some room in the antechamber to work with. So in this particular case, the patient had shallow AC, so I had to put in some cohesive viscoelastic to just to fill in the antechamber and make it deep. And I didn't want to use the main port because with the leakage of OVDs, the need to refill the antechamber is much more with the if you are using main port. So these microrhexis forceps, you can just enter through the side port and you don't need to disturb the main port. So the leakage of viscoelastic substance is very less. Yes, and thus you don't need to refill the antechamber again and again in these difficult cases. So the cases where this shallow AC or the pressure gradient is not in our favor, in these cases, these microaxis forceps and entry from a side port, these are very important points in my view. Also keeping the balance. So like as I already told you, the interlenticular pressure, if it is higher than the antechamber pressure, then the chances of rhexis runout are much more. So if you see in this case, as I'm tapping the anterior lens capsule, the milky fluid just keeps moving away and then comes back. So this indicates that the lens is filled of liquefied cortical matter, and as soon as we make the initial puncture, we can see that the liquefied cortical matter is coming out. So we need to keep filling the anterior chamber with the viscoelastic substance. And if you notice the pressure, the kind of stretch which I'm putting on the capsule is more towards centripetally, because I don't want the rhexis to run out. We can always make the rhexis bigger later on if the need be, but we don't want the rhexis to run out. So like in this case, so the another way to bring the pressure gradient in our favor would be, so one way we studied that you can increase the pressure in the anterior chamber. The another way would be to debulk the lens. So if you debulk the lens, the interlenticular pressure goes down. So to debulk the lens, you can just initially create a small rhexis and then later on extend it. So the small rhexis, when you are creating the smaller rhexis, you can, I prefer to use forceps in the intumescent cataracts because the risk of runout is very high. And with the forcep, you can always put in the centripetal force more effectively. So like in this case, I'm mostly providing the centripetal force only, and still the rhexis is trying to run out. So this is a smaller rhexis which I made, and then just deflated the lens and inflated the anterior chamber with the viscoelastic substance. So we just need to remove the excess cortical matter from the lens, and then we can proceed with the second rhexis as in any normal case. So so this is how you can bring in the odds in our favor in complicated cases also. So we need to understand so we are done with the kind of pressure gradient which we are to see in the making of capsulorhexis, but we need to also understand the elastic nature of capsule. So if you see this elastic nature is more apparent in pediatric cases. So if this is a pediatric cataract case, and if you see that the lens capsule while I'm making the rhexis, so it's very elastic, and mostly I'm just trying to put in the centripetal force only, and still the rhexis size which I ended up was optimum. So you don't need to like more, you need to tilt your balance towards steering force rather than shearing force. So in this case, you need to keep pulling centripetally and mainly apply tearing force, and I feel in these cases forceps work better. Just the last point to dig deeper a bit into the shearing and tearing force if you have any confusion. So, like in this case, this is a normal case. We are making the axis as we normally make. The flap edge is parallel to the lens surface, and we are applying pressure in that direction only. But at this last point, look at, okay, so I've slowed the video, and if you see at last point when I thought that the rhexis is trying to run out, and just a centripetal force. So this kind of little maneuver you can apply whenever you feel that the rhexis is getting running out. So the crux is that you need to keep in mind these things: the pressure gradient, how is the pressure gradient, what kind of force you want to apply, and try to understand or comprehend the elastic nature of the lens capsule, what's the age of patient, and how the capsule is behaving. So then in any scenario we can modify the approach a little bit. Thank you.
Thank you, sir. That was a wonderful presentation and surely a comprehensive guide to performing capsulorhexis. So I would like to ask our expert panelist, Dr. Harshul sir, for his expert comments.
Yeah. So I think Dr. Sandeep, that was a really very nice presentation.
Thank you, sir.
And you covered, I think, almost all the aspects that how one should perform capsulorhexis in various scenarios. He rightly said that whenever we are encountering any pressure, centrifugal, which is more, then there is a place to use forceps. Not even in the intumescent cataract or in a Morgagnon cataract, but also there are many cases we see. So the once we initiate capsulorhexis with needle and we try to fashion the flap, we see that there are a lot of time the chamber is shallow or the lens is, its dome is like this. It's not flattened. So that's the time you need to use forceps, because with forceps, as he showed very rightly, you can always control the tear. You are basically controlling where you want to take the tear. But with needle, you can't control much. So if we have, there is no increased interlenticular pressure, capsule is flat, in those cases only you can use needle cystitome correctly. But whenever there is increased pressure, you need to use forceps, especially in pediatric or young cases, right? Secondly, about sizing of capsulorhexis, we know that with today's IOLs, which we are using, all multifocal, trifocals, toric, or all aspheric IOLs, we need perfect overlap of the IOL optic because we need good effective lens position. We want that lens should be locked nicely in the capsular bag. If we have a bigger axis, the lens will try to shift forward and it will get a myopic surprise. If our capsular axis is very small, we'll have capsular phimosis that will again subluxate the lens. So the sizing of capsular axis is of utmost importance. So initially, beginner can always use a corneal marker, which he rightly showed. If you are new, you can use that corneal marker as a guide to the sizing of the capsulorhexis. And secondly, if you have a smaller capsulorhexis, so once you put the IOL, that's the perfect guide that what is the size of capsulorhexis. I always advise you to err on the side of the smaller axis. In like 20-25% of my cases, also my axis is smaller in the end. So I go and do secondary enlargement. So that you should always learn how to do secondary enlargement of the rhexis. I'll be also showing some videos. You go ahead and put OVD and give oblique cut and then use. So you have to get used to these micro scissors, these micro forceps. As I always say, in cricket, you need to learn all the shots of cricket. You have to use cystitome, you have to use micro forceps, you used to use micro scissors. So everything you have to be ambidextrous, because many a times you need to go use your left hand. You need to go with left hand and cut with left hand, use forceps from left hand. So practice that. That is the key to success in achieving good capsulorhexis. because it's not always a rosy picture, We have intumescent, lens-induced glaucoma, Morgandian, different kind of cataract. And something about small pupil staining, um, one thing we can do is, if possible, just go beneath the pupillary margin and try to put dye there. It may sometimes stain, but you're not always lucky, because the moment you give paracentesis, the entire aqueous comes out and chamber becomes flatter. It's not always possible. So secondly, as he showed, you put whatever malignant ring or whatever device you want to use, iris soaks. But after that, make sure that either you paint it nicely, or if you're not able to paint with the OVD, you try to wash off the entire OVD first and again do painting. But believe me, before you get a good staining, don't try to make Capsulorhexis. Otherwise, life is in hell. So these are, I think, few points, and I'll add some more after Nilesh pitch in, and we have some more videos. Yeah.
Thank you, sir. So
Thank you so much. Thank you so much, sir, for those pearls. I think I just missed. Hello.
Yeah, Nilesh. Yeah.
So for me also, sir, the go-to forceps has now become Haldipur ka forceps. I think it has given excellent chamber stability and very well controlled. And again, as you said, micro rhexis forceps are the way to go. One thing that like every video he showed was very to the point. Like it was very meticulous and precise. The only one thing that I do differently than what he has shown is, when I have to put iris hook, I usually make a side port, go below the pupil, stain the capsule first, wash it, and then start with the iris hook or BX ring or whatever it is, because the OVD will give poor staining. So any beginner who is starting, I don't think this is a good idea. In hands of expert, I think staining under OVD works. But for beginners, I think it is better to go below the iris and do this.
Yeah.
Apart from that, every point that you have made. So yes, sir, please.
Yeah. Another thing is, whenever you are using Utrata forceps, I've seen that there's the time when, especially in the subincisional area, there's the time when the OVD leaks and you have rhexis runoff. So you should always be careful that you try to go away from the incision first, and when you are coming to subincisional area, you try to just finish in one go rhexis. So that's the way. Or either, what I prefer is, of course, micro forceps. So you go through another side port so that you don't have any subincisional kind of area.
Yes, sir. Perfect.
Thank
Dr.
you.
Lippy?
Yes. So moving on to our next speaker, Dr. Deeksha Rani. She is a consultant at Krishna Eye Center, Mumbai. She has done her MD from RPC AIMS and SRship from RPC AIMS. She has multiple publications and has authored various chapters in various textbooks. She has also won various awards at national and international conferences. She will be discussing the Capsulorhexis in challenging situations. Over to you, ma'am.
Hi, good evening, everyone. Thank you, Lippy, for the introduction. Shall I just share my slides?
Yes, ma'am.
Yeah. I hope my slides are visible.
Yes, ma'am, they are visible.
Okay. So we'll be discussing about Capsulorhexis in challenging situation. Dr. Sandeep has very nicely covered the basics of Capsulorhexis. So I'll be covering certain scenarios, like certain cases or certain presentations of cataracts that make rhexis difficult. And in few cases, we have certain rhexi that can make the further surgery difficult. I'll also be discussing certain rescue techniques. And in the final section, we'll discuss certain challenging scenarios where a slight modification is needed for Capsulorhexis. So physics of Capsulorhexis about sharing and ripping force has been very nicely covered by Dr. Sandeep, so I'll be skipping it. So coming to what all can go wrong, your rhexis may end up being too small. It may be too large, it may run out, or there might be other challenging cases, which you do not want. So you'll be taking all of them one by one. So starting with certain cataracts, which can make your rhexis difficult. First scenario is small pupil. If you're using a pupil expander or a Malyugin ring, then it's good. How to stain has already been discussed. But if you're not using a pupil expander, do not fall into the trap of a small rhexis because of a small pupil. So in this, you can see the pupil is around 5 to 5.5 mm and the rhexis is around 3.5 mm. This might look that it is adequately sized, but it is quite small. Next, we have in intumescent cataracts, there can be high interlenticular pressure and the rhexis tends to run outwards. We can have Argentinian flag. In hypermature cataracts, the milky fluid may leak out or nick in rhexis. This may hamper visibility. In addition, such cases might also have a fibrosis of capsule, or the capsule may be really friable in these cases. Again, in 2 young patients, there could be increased elasticity of capsule and there is higher vitreous thrust. Again, the rhexis tends to be larger. So here we have targeted a 5 mm rhexis, but the rhexis ended out to be slightly larger. In certain cases, you can have an anomalous anatomy, like in this case of anterior lenticonus, the conic part of the lens is abnormally brittle. This may lead to irregular rhexis. And in subluxated cataracts, pulling away from the weak zonules can increase the luxation. In post-traumatic cataracts, we can have abnormal anatomy, shallow AC, and certain other surprises inside the eye, which may make things challenging. And this is another case of shallow AC, where this is a patient with iridofundal coloboma, has been operated, VR surgery, it's an oil-filled eye. Again, there's a shallow AC and increased, upthrust from posterior chamber due to the oil, which can make things difficult. Now we'll discuss certain situations where rhexis has been done, but after the rhexis, just because of the rhexis, the surgery became difficult. For example, the rhexis was small. If the rhexis is small, it can lead to difficult hydrodissection, difficult manipulation because your space inside the eye is limited, your working space is decreased. You can have multiple nicks on the rhexis margin by the time you finish up your case, and if it's not a good day, then these nips can extend posteriorly. Large rhexis, again, poor decentration, and sometimes you can have certain irregular rhexis like this, which is something which you definitely would not want. And rarely the rhexis can also, go posteriorly and turn into a PCR. Now we'll just discuss one case and we'll discuss how to rescue a running out rhexis. So before beginning, we need to build up our armamentarium. We have discussed various type of forceps which are used, which are available, like Haldipur forceps, we have microrhexis forceps, we have Utrata forceps. But to all those, I would like to add one forceps, which is my favorite, that is the ileum peeling forceps, that is the vitreoretinal ileum peeling forceps. And this is one of my favorites to control a running out rhexis. I have used various forceps, but this is something which gives me excellent control, especially the 25 gauge. It is really flexible. You can go through side port and you can have reach in difficult scenarios as well. And in addition to that, you need viscoelastics, all types of viscoelastics, and heavy ones, especially you are dealing with cases of high intralenticular pressure or higher vitreous upthrust. So the first thing is that you need to detect early. So do not go with the flow when you can see that the direction is not right. So here you can see the rhexis has begun to go out. So this is the time when you stop, think, refill the vitreous chamber, and get ready for next part. Next is a strategic incision, either the main port or through the side port, through which you can use your forceps, and an adequate viscoelastic for a flatter capsule so that you can maneuver and pull the rhexis back into control. So during this procedure, after the rhexis has been done, use all your senses at 200%, do a very low slow phaco, and if the rhexis has gone beyond, do not hesitate to convert it into SICS or ECCE. And during the entire surgery, we need to keep an eye on rhexis margin and especially look for something known as flap motility sign. So if your rhexis has extended towards the zonules, usually you'll see the 2 edges of the extended rhexis, coming towards the anterior chamber. However, if during the surgery, the extension goes into the posterior chamber, that is, it goes beyond the zonules, the flaps of the anterior capsule will suddenly dip downwards. So this is the sign which, which will give you an idea that something is wrong and we need to stop and reassess. And there's another case where I would like to show managing Argentinian flag, which is one of the quite challenging situations, especially in intumescent cataracts, the cataracts having high intralenticular pressure. So in this case, after filling a heavy OVD, a small nick has been given and it immediately, runs out into the periphery, presenting as a typical Argentinian flag. Now, managing in this case is little tricky, but not too difficult, because mostly this extension does not go beyond the zonules. So you can just convert the adjacent flaps into rhexi with the scissors and forceps, and you can proceed with the surgery, of course, at low settings and at low speed, making, a close eye on the rhexis margin during the entire surgery. And in most of the cases, trust me, you can end up with IOL in the bag without need of any anterior vitrectomy. So here I would like to show this classification of white cataracts, which has been described by Dr. Tityal. The paper is typically on intraoperative OCT guided imaging, but even preoperative anterior segment OCT can give a good picture. So there are 4 main types of senile white cataracts. In the first one, you have a normal appearance of the cortical lamellae. This is something where we need not worry. A normal single stage forceps, as you would do in any other immature cataract case, would work equally well. In type 2 cataracts, we have swollen lenses, swollen lens fibers, as well as in multiple fluid clips within the lens fibers. So these are the cases where intralenticular pressure is really high. In this, the best approach is a double rhexis technique, in which we first make a small central rhexis, then we aspirate using irrigation and aspiration to reduce the intralenticular pressure, and then we enlarge the rhexis. Type 3 is somewhere between 2 and 4, in which the intralenticular pressure is raised, but not as high as type 2, because there's increased turbid liquid just underneath the capsule. Here again, you need double rhexis or maybe a small nick, and then aspiration of the cortex under the capsule would work. Type 4 is typically seen in a hypermature cataract, where you have a ground glass appearance. That means that this entire area is filled up with just milky fluid. Just one nick and the entire fluid will come out. So here you need not worry about running out. It's just that you have to make sure the entire fluid seeps out of the anterior chamber, and then refill the OVD and complete the rhexis. So now I would show certain challenging cases. So this patient presented to us where some surgery was being done outside and it was abandoned due to some reason. So here you can see there is some fibrosis. So in such cases, staining is mandatory to look for the edges. And here just do not, go overdo things. Just a small nick and a small rhexis to get some access to the working area, so that we can just emulsify the cataract and proceed. Further settings can be done after the IOL implantation. Now again, as I was saying, small pupil does not mean a small rhexis. Again, this is not too small a pupil, but approximately 5 millimeter. So here, you have to ensure that your rhexis, matches the pupillary margin, and sometimes even it may go underneath the pupillary margin. Do not fall into the trap of a small rhexis in patients with small pupil. So this is the case when you have no support. This patient has 360 degrees zonular weakness, and there are folds here. If you proceed your rhexis with a cystitome, you can see the zonular weakness, which can be extended, which can enlarge. So in such cases, having a forceps is mandatory. Go slow, spend time. You can do multiple attempts, make small openings. The thing is that, the case should not go out of hands, because if the rhexis goes beyond a certain margin, it can be really unsalvageable. So you can have multiple nicks and you can, slowly enlarge the rhexis. So this is another patient with post-traumatic cataract. We have an iridodialysis and anterior capsule rupture with the iris plugging the wound. So here, now since the central part is fibrosed, you cannot initiate a normal rhexis here. So what we do is, after we remove these synechiae with viscoelastics, with viscoelastic substance, we now need to go around this fibrosis. You cannot use, and doing anything here would be wasteful. Just make a small nick, enlarge it with a scissors, and cover this entire thing in one go with a forceps, as can be seen here. So this way, the entire fibrotic thing can be taken care of. So next is cut when you can't peel. These are certain rare scenarios, but I think it is important to discuss because such techniques can be needed anywhere. So this is a pediatric patient with anterior capsular plaque. Again, you can see there is no normal capsule to initiate a rhexis. So what we do is we can use MVR blade or any sideport blade to make vertical nicks, cruciate incisions. And then with the micro scissors, you can just join all these small nicks and you'll have a good working space. So again, here we cannot call it a capsulorhexis because it is not a rhexis. It's of course a capsulotomy. But this is what is needed in this patient. So after creating all the multiple nicks, the flap can be removed and pulled out with a forceps. So when things are eccentric, define your center. So this is a patient with subluxated cataract. Now here, the center has to be the center of the rhexis. You cannot, center the rhexis on the Purkinje images. It has to be the center of lens and not the center of pupil. And at the same time, you're not supposed to pull the rhexis away from the zonules. The direction should be towards the zonules and not away from it. So the rhexis is being initiated in the periphery because this is where the center of the lens lies. Again, using forceps is a great thing, and my personal favorite. When there's anything abnormal inside the eye, I tend to use forceps. And here you go. So I think double rhexis was shown by Dr. Sandeep very beautifully. So this is another patient with increased intralenticular pressure. Here, a small 2 to 2.5 mm rhexis has been made. And then we need to, reduce the intralenticular pressure, which cannot be always achieved with a cannula. So it is better to aspirate and make sure the pressure has really gone down and then refill the chamber with viscoelastic before you proceed to enlarge the rhexis. So capsulorhexis in pediatric cataracts. Now, pediatric cataracts have peculiar things in them. First is the capsule is, really elastic, and you have increased vitreous upthrust. So the dome of the anterior capsule is like this. So you need to flatten out the dome before you start working with a heavier viscoelastic. So Helon GV, which is heavier, would be better, which would, help to flatten the interior capsule so that you have better pressure balance inside the eye and things can work in your favor. Again, with the forceps, target a smaller rhexis because it will end up being bigger. And you can always use these image guiding systems or the corneal marks to give a guide to your size of your rhexis. Again, as Dr. Harshal rightly said, we need to enlarge the rhexis sometimes. It's never too late to readjust. You may finish up your surgery with a small rhexis, but at the end, after IOL implantation, make sure to readjust the size so that you have a good apposition between the capsule and the lens. And at the same time, you can also avoid capsular phimosis. So this is one peculiar case that I would like to show. This patient has anterior lenticonus, and you can see the anterior capsule is too thin and too brittle that even with the forceps, the pull is not very smooth. So despite using all the precautions, we are having a very brittle outline and there's an increased tendency for this again to run outwards. So again, since the cataract was soft, we finished up with a small rhexis, aspirated the lens matter, and then we enlarged the rhexis after implanting the IOL. So again, experience is making mistakes and learning from them. And I would like to end on this note. Thank you.
Thank you so much, Dr. Divya. Harshal sir, your comments on
Yeah. I think
everything
that
was
was a
very beautifully
wonderful,
explained.
yeah, that was a wonderful collection of so many cases which Dr. Diksha showed very nicely. Few things I'd like to add is another biggest problem in smaller rhexis. If you make a very small rhexis, is of course, as she mentioned, you may damage it while chopping the nucleus. Another thing is you may create zonodilisis, no, when you're doing irrigation aspiration. So that is the biggest problem. So you should always try that you don't have very small rhexis. If it's a small rhexis, before doing nucleotomy, of course, you can enlarge it if you are confident enough, if you have certain level of expertise. Otherwise, you should be very careful while doing IA in very small rhexis. Second thing is when you are choosing a micro capsulorhexis forceps, one thing you should always look for is the where is the hinge of that forceps, because in many forceps you will see that the hinge is very big. So it's very difficult with even these, even though these are micro forceps goes through 23 gauge incision, but when you're trying to go through main port, it's difficult to grasp from sub-incisional area, and because that hinge comes in between. So there are many forceps like MST, which Epsilon also makes, which have very small hinge. So those forceps are better as compared to the micro forceps, which have a bigger hinge. And of course, as the pediatric cataract, which he showed very nicely, I think if you have a cataract like that, which is almost, of the size of 5.5 millimeter, the view becomes very difficult, even in retro mode of Lumira microscopes. So you should always stain those capsules so that when
Yes.
you're doing capsulorhexis, you can easily see that. Otherwise, I think she very nicely covered all the points. Nilesh?
Yes, sir. I think a very beautiful bouquet of difficult cases. There are multiple learning points in the presentation. I agree with sir what sir is telling us. Not only in IS, sir. I think if the nucleus size is bigger, then again
Yeah.
won't come out in like bigger chunks. So you have, if you have smaller rhexis, then try to make as small pieces as possible before you start emulsifying for the beginners. And the another point that I want to make for the intimation cataract is a tip that Harbans Lal sir gave, and I am practicing it, is to massage the capsule. So when you massage the capsule, it breaks those fluid pockets, and it will come into a central. So once you nick, the fluid comes out, and you won't get that sudden increased pressure and the runoff. So that is a very good tip that he gave, and I'm practicing for last 1 year. I think last in Singapore conference he had given, and I rarely have a runoff after that. I use it with the soft shell technique. So otherwise, nice
Yeah.
presentation.
Thank you. Thanks.
Yeah, I would just like to add, rest of everything was fine. We least mentioned about the hard cataracts and brown cataracts, which obviously the beginners may not be doing much. In that cases, we have to modify the size of the rhexis. We can go beyond 5 or 6 mm. We can take it as 7 mm also, so that it will be easy to chop the nucleus, and the manipulation inside the bag would be much better in that cases. So yeah, we'll go ahead with the final presentation of the day. And I welcome Dr. Arunjit. He is a consultant cataract and vitreoretinal consultant at BBI Foundation, Kolkata, and assistant professor Ram Mission Seva Pratishthan and WIMS Kolkata. He is also the recipient of IGO Platinum Award in 2021. He is a recipient of Tamil Nadu Ophthalmology Award in Gold Medal for the year 2021. He has 30 PubMed's index publications in his name, and also he is a section editor in Retina section in Tamil Nadu Journal of Ophthalmological Sciences. He is also a subcommittee member of Ophthalmological Society of West Bengal and a very dynamic and young person in our Young Ophthalmological Society group as well. Anujit, you can, I think, go ahead with the presentation.
Thank you so much, Dr. Anup, for that kind introduction. I'll just start sharing my screen. I think the previous speakers have made my job extremely easy because they've covered a lot of things which I put in recent advances, but it looks like Looks like most of them are covered, so that makes my job a little bit easier, but I'll still try to go across wherever I feel things can be explained a bit more. So I'll just move this to the side. And so the very first thing that I thought I'd speak about is the advancement of techniques of Capsulorhexis actually started from understanding tangential forces. So one small thing which I employ when I teach my residents is that if you can see the red line is that when you start off your rhexis, what I tell residents is that please go 1 clock hour forward. If you see the rhexis is running away, start going 1 clock hour inward. So that has been later modified as Brian Little's technique as we all know it, but that actually helps residents go easier through every single clock hour going forward. And whenever they feel any difficulty, they can either inject viscoelastic or make the surgery slightly easier by taking a deep breath and following this technique. So even this has been covered. So I was speaking about instrumentation, but for residents, please do not forget your trusty 26-gauge cystotome. It is still what many surgeons go back to, even though forceps does make life easier. So small video on forceps. So you can nick the anterior capsule any which way you want. A lot of people prefer using a cystotome to nick the capsule and going ahead with forceps. So over here, you can see that the surgeon is always going 1 clock hour forward and reassessing the rhexis. And the important thing is to try to maintain the same circle which you are trying to go with. So for example, you're aiming for a 5 mm circle. Notice how the surgeon is making sure that with the tip of the forceps, he or she is trying to trace the circle that the surgeon wants to create. Never hesitate to stop in the middle and re-inject viscoelastics. And whenever you see that your rhexis is turning out short, with forceps, it's very easy to take a small sliver from the edge of your rhexis and extend the rhexis going forward. So extending spirally if required does help later in the future. And once again, even before the last step, injecting viscoelastic so that you grab the rhexis at the right margin and you can complete your rhexis. So advancing to forceps is something which requires a bit of patience, because I believe it does have a very steep learning curve, though it does provide a lot of stability that has been discussed. And you can see adept surgeons using the forceps with a lot of speed. So as a resident, shifting to forceps is something which you can try at the later end or the flag end, but it's something to always keep in mind, especially when you're in a pinch, especially with runaway rhexises, etc. So actually, the only thing left for me to speak about is using femtolaser for your rhexis or your capsulotomies. So whenever you see an image like this nowadays in quizzes, this is the photo that they put in front of you, and they usually point at disc and ask you what's exactly going on. So the main thing to remember when you're talking about a femtocapsulotomy is that the femtosecond laser machine is already doing the capsulotomy for you. So usually it does the radial and the arcuate incisions, it does the nuclear fragmentation, and it does the capsulotomy. I'm not stressing too much on the interface because depending on the machine, the interface also varies. So the principle here for femtolaser capsulotomy is that a near-infrared laser of 1053 nanometer with ultra-short laser pulses delivers localized energy into the transparent tissues like the anterior capsular margin, and this creates photon energy which generates and ionizes the plasma and breaks it down, which is a common term that we use, photodisruption. And these photodisruption creates small cavitation bubbles, and this can rupture the tissue without any collateral damage. So the machine has actually mapped normal corneas, normal iris, as well as normal lens anatomy so that it can precisely predict the location. And surgeons in using femto machines can actually alter the size as well as the location, as well as make it off-center. So it's actually very preferable in case of hard cataracts, in case of white cataracts, in case of subluxated cataracts where you want a decentered capsulotomy. Like Dr. Diksha was saying, that the shearing forces in slightly subluxated cataracts becomes a problem. And there are various studies which have shown that the uniformity and the predictability of femtolasers compared to manual rhexises, as I'm showing over here, has shown to be superior. So this is another small surgery. So this is after the patient has been docked off the femto machine and you are trying to continue the cataract surgery with phaco. So you can see over here that from the margin close to the incision, the rhexis margin has been stabilized, but sometimes there might be some sort of a capsular tag. So in this case, I actually had to redo the rhexis at that corner with the help of a cystotome so that I could separate it. Usually this doesn't happen, but there are some cases in which this may happen. So the thing to remember that if you are a young surgeon shifting to femtocapsulotomy, or you do have a femto machine in your center which you are practicing, definitely there is better circularity and there is more uniformity. Predictability is something which varies because some femto machines perform some steps better than the others. However, if you are in training, my suggestion would be to actually master your manual capsulorhexis as well and keep femto definitely for cases where you want extra precision or you don't want a decentration of your rhexis. So it's important to know some limitations of femtocapsulotomy. So one thing is that one of the major limitations are small pupils. In these cases, femtorhexis doesn't work too well. It is known that the femto machine laser sometimes causes some amount of intraoperative miosis. That means when the patient is docked on the femto machine, you may have an 8 mm well-dilated pupil. But once you shift the patient to your operating microscope, the dilatation may decrease. There is some amount of potential rhexis tags that may occur, and there is a certain cost to bear when it comes to these things. Something interesting in the advancement that I noticed, so I was going through a couple, some literature over here to understand what are the other advancements that we know. So this was something very interesting that I feel that is more attuned to residents and they can even perform it. This article was published by Dr. Mithun Tulsidas. He's a very dynamic young O, and he's called it flow capsulorhexis. So what he's done is that in case of white cataracts in mature and hypermature cataracts, he's attached the cystotome to a BSS flow cannula. And what happens is that as he's nicking the anterior capsule, there is also flow coming out, which is a modified version of what usually sometimes residents do, is attaching it to a syringe and using the other hand to inject some fluid. And this flow of BSS into the eye actually stabilizes any amount of milky fluid that may tend to come out of it. And he has shown that the success rate over here, group 1 was his flow and group 2 was the traditional method, and he has shown a higher success rate in this case. So this is, I think, quite interesting. It's a recent advance. It's a novel technique, and I feel that maybe it can be incorporated. So some take-home message, especially for residents, is that this has been discussed in detail today, but understanding capsular dynamics and intralenticular pressure is very important. Understanding when to use a cystotome, when to use a forceps, and when to shift to a forceps is very important. If you have the opportunity to use a femtosecond laser, you must weigh the pros and cons. Definitely, there are a lot of pros, and femtosecond is upcoming and it is the future. But as a resident, it's quite important to remember that no matter how fast we are advancing, it's very important when you're doing a capsulorhexis is to always maintain a stable AC, go 1 clock hour at a time, keep the flap resting down, trace the circle that you want to achieve. Thank you so much.
Thank you, Dr. Anuji. That was a wonderful presentation. I hope our residents and all the beginners have been benefited. They have learned all the basics along with the advanced techniques of capsulorhexis. I would like Dr. Harshul sir for his experts and tips.
Yeah, so seeing Anuji, I don't feel that Ajeda is no more with us. He was a great friend and a, very prolific surgeon, cataract and retinal surgeon. And Anujit, it was a really very nice presentation, and I wish you all the success. Yeah.
Thank you, sir.
Yeah.
Nilesh.
Yeah, as Anujit is a brilliant speaker, and we have seen him present. I think I am seeing him for the last 3 or 4 years, and his each talk gets better and better. So congratulations on that, Anujit. I personally have no experience with femtoseconds, so all the knowledge that I have is by seeing these kind of presentations. So I don't think I'm good enough to make any comment on this presentation.
Thank you, sir.
So
Yeah.
we should.
I would like.
Sir, shall we ask the resident, or shall we have this? Shall we have Harshu's video first and then ask the residents for any query they have?
We can have Harshu sir's video first, and then if there are any queries from the residents, we can ask them.
Perfect, perfect.
Meanwhile,
Okay.
if our viewers have any questions and queries, they can put forward a message in the chat section so that we can discuss this later at the end of the presentation. Yes, Harshul, sure. You can start. I guess.
Yes. So I'll be showing you some videos to, further clarify certain things which I think are important. Can you see my screen?
Yes, sir, visible. Yes, sir.
Okay, so the first thing which we are discussing about intumescent cataract is we all know there is increased intracapsular pressure. So I started using sequential two-stage rhexis. I presented it in AIOC 2011, and after that I've been teaching this and all the platforms. And I think this is the technique which works best in these kind of cataract. The correct way to do is the moment you nick it, try to make your rhexis curvilinear. The moment you lift the flap, let it be curvilinear. Go ahead and put some viscoat or something in front of it here, so that you again just flatten this flap and use a micro forceps to make a very small rhexis, the smallest which is possible. So just go ahead and make a very small rhexis there. And once you have this small rhexis, now it's important that we debulk the almost capsule from all the sides, because there is increased pressure everywhere, as you can see in this area. So you go ahead and use this 26 gauge cannula. And the moment you suck all this fluid, you see it's get decompressed, but only from this area. So it's important that you decompress from this area, then go from side port also. So go from, again put OVD, go from side port and try to debulk this area. So in this way, it's important that you go from main port and from both the side ports and try to debulk most of the capsular bag. So here I'm going to another side port. And believe me, this time which you spend here debulking, it's worth it. Because once you debulk the capsular bag in these almost 3 quadrants, it decreases down intracapsular pressure, and then you need to give an oblique cut there and use a micro forceps. As you can see here, there is no raised pressure now. So I think this way of decompression is very important, which one should always try to do. Then another video which I want to show here is okay. So as we were discussing, and Dr. Anujit was also saying that we should always look at the leading edge, that where this leading edge is going. So once you see that this edge is going outwards, so this is the forces which you should always remember is the centripetal force or the Brian Little's technique, whatever you call. So you go ahead, stop at that point. Now there is no use of cystitome at this point, because now you need Capsulorhexis forceps. So I'm taking forceps and look at the direction of my forceps. It's going towards center. Look at the leading edge where it's coming. It's coming right back on the track. So your direction of pull towards center, again, in slow motion, I go and grasp here and pull the forceps towards the center. And look at the leading edge where it's coming right back on the track. And once you see that it's come back on the track, then you can complete the Capsulorhexis. So this is the way you should always. Another case, this mid-dilated pupil. again, see what's happening here is it's a shallow anterior chamber. Rhexis is going beneath the pupillary margin. I can't see that rhexis. So don't do anything blindly. So one trick here is, if you want to see the edge without seeing the edge, where the edge of the tear is, you can't pull it. So I'm going here in front of where the tear is, and I'm making a side port and putting iris hook there, and going from this area so that I don't catch the torn edge there. Again, putting some OVD before putting hook. And once you put this hook, you can see that where the tear is. And see, now I can see where my tear is, and I'm getting it back into the right track. Again, look at the pull of the forceps. So you need to improvise many a times whenever you have a situation like this. So you can use iris hooks at this point, and again, it comes back in the right path. Again, intumescent cataract, the same thing. What I want to show here is, we are discussing about fibrotic capsule. So whenever we have something capsule like this, we can't, as Dr. Diksha also showed, that we have to cut through these fibrotic areas. So we need to go through, maybe you need 1 or 2 extra side ports, but it's worth it. So you go ahead and cut through these fibrotic areas. And the beauty is that these fibrotic areas, they're very strong. They don't give way. So you can easily cut through these fibrotic areas with micro scissors, and then it completes the capsulorhexis. And of course, secondary enlargement, you can even do it under hydro. So once I put the IOL, you can see here, I'm just putting my irrigation on and completing capsulorhexis here, enlarging. Another case, just go ahead and give one this oblique cut. Don't give radial cut. Give oblique cut there and use micro forceps to make the rhexis of perfect size in the end. Again, so you need to use both hands. Here I'm using my left hand, going through side port and enlarging the rhexis. So try to use both the hands, because you never know when you need your right hand or left hand. I think with this I'll finish. There's a whole lot of videos which we can discuss. Thank you so much.
Thank you so
I
much.
thought yeah.
They were all some of the wonderful tips. So moving on to the residents, we have Dr. Aditya and Dr. Nikita on the resident hot seats tonight. So can we have a few words, any doubts? Dr. Aditya?
Good evening, ma'am. Ma'am, it was a wonderful section. I don't have much doubts, but how to approach a case of hypermature cataract, Morgagnan cataract in case of rhexis?
So, Dr. Diksha, can you please take up this question?
Fine. Yeah, so for regarding hypermature cataracts, again, you have to look for certain things. First is, usually the hypermature cataracts are filled with milky fluid inside the lens. So a small nick would lead to egress of the entire milky fluid, and that would immediately lower down the intralenticular pressure. However, if the process of conversion into hypermature cataract is not complete, certain areas you can have a raised intralenticular pressure. So again, start your exes, be slow, be sure that your visibility is good. Keep on washing out or replacing or flushing it with viscoelastic, whatever fluid egresses. And then slowly with the forceps, you can proceed. And if you can often, counter with areas of fibrosis and irregular and brittle capsule. So those cases, if you're not very careful, they may immediately rip into the periphery. So in those cases, you may even need scissors or maybe something like a can opener thing to, convert that rigs into a rip and or go beyond the area of fibrosis so that you have a better rhexis.
Thank you, ma'am. Ma'am, in case of SACS, sometimes we will give radial nicks to deliver the nucleus. Is precaution before giving
All right. So while giving radial nicks, you may easily give if you're going to deliver the nucleus, especially in SICS. If the rhexis is small, you can give certain radial nicks, but be sure that they do not, go all the way towards the zonules. Small nicks with scissors or maybe even with a cystotome can, easily enlarge the place and help delivering of the nucleus well, especially important in harder cataracts.
Okay, ma'am. Thank you, ma'am.
Nilesh, sir, would you like to add something?
For the hypermature cataract, I think what Dr. Disha told is very much applicable. Sometimes, like when the complete cortex is like liquefied, what I do is I inject, like, make a baby rhexis, as Harshul sir told, but pulling too much force, the zonular dialysis can happen. So what I do is make a three like 180-degree flap, inject some viscoelastic so that there is an increased interlenticular pressure that I artificially create, not overfill it so that it won't create an Argentinian flag sign, and then complete the rhexis over that visco. So that helps. Harshul sir, anything else to be done?
Yeah, I think in Morgangian cataract, what Dr. Aditya was asking, their problem is not of raised pressure. The moment you give neck, the entire cortical fluid matter, it keeps coming. So you need to wash it off, before you can see the leading edge of the capsulorhexis. So that's a problem. So again, you need to, or either put a good OVD, so that will just push it back, everything. But the real problem there is, of course, of the friable capsule. And there are many times plaque you will see on the anterior capsule. Zonules are weak. So when you're trying to make capsulorhexis, zonules are very weak on those cases. Then, of course, there is a mobile nucleus. Many times it's very hard. So it's difficult to chop these kind of nucleus. So there, if you just hold the nucleus in center and give a chop from equator, what is called as a horizontal chop, that works best in these kind of cases. Or if you feel that the laxity is so much, then that you're not able to chop, then you can even put a CTR ring before you try to chop. So what CTR ring does is it stretches the capsular bag. That makes chopping a little easier in the difficult cases.
Yes, sir.
Sometimes even injecting viscoelastic under that nucleus in the bag again gives a cushion to keep the PC behind.
Yeah. But the thing is that which viscoelastic, because normal viscoelastic will come off. So if you have
HPMC,
of course,
preferably HPMC.
I think
Or maybe
viscodispersive
or HPMC.
Viscodispersive.
Yeah. Yes.
Thank you, sir. Thank you, Dr. Aditya. I hope your doubts are cleared now. Dr. Nikita?
Yes, good evening, ma'am and sir. Sir, according to you, a beginner should use which instrument for capsulorhexis, utrata forceps or cystitome?
Dr. Anujit?
So as a beginner, you should primarily use a cystitome. My sincere advice is that please bend your cystitome yourself, even if you're in a DNB institute and the cystitome is already coming bent for you. Most importantly is that I'll answer the question in the chat box as well. Dr. Roshali is asking how to practice capsulorhexis before you can do it directly on patients. So I practiced on a grape. So what you do is that you will get an OT table or a OT place where you can put the grape under the microscope. People have practiced on tomatoes. There are some IOL boxes, like APPA IOL boxes, where the cellophane on top of the IOL has also been used by many residents to practice. So the ideal thing is to firstly, more than practicing capsulorhexis, is to try to understand depth of focus, because that's what goes wrong. Secondly, when you are initially blocking your patients before doing surgery, as you would as a resident, it is important to keep your eye in primary position, because what you think is a circle in the beginning turns out to be oval or an ellipsoid. Thirdly, the most important thing is to keep your the hypothenar eminence of your hand resting somewhere so that you enter from the sides and don't enter from the top. So these are few things that you must keep telling yourself in your head before you even enter the eye, that your hand should be stable somewhere over here. You should be holding your cystitome, whether on a syringe or a rhexis holder or whatever, in a pen holding fashion. Dip your hand and put it in and then make it straight. And definitely you should start with a 26 gauge cystotome. Different people have different amounts of bending of the initial tip. So some people prefer a larger bend, some people prefer a softer bend, some people prefer a 90-degree bend. If you ask me, if you go slightly lesser than 90 degrees and you nick the capsule, you can put the capsule slightly above your cystotome as you extend it and raise the flap and put the flap back down. So maybe repeating these 3 steps and watching videos in the evening before your surgical case the next day means that even if you're panicking on the morning of the surgery, at least these three steps will go fine. So that's my 2 cents. I would also love Sir to add his points.
Yeah, very valid points, Anujit. I think 2-3 points I'd like to add, as Dr. Sandeep showed very nicely. When you are using cystotome, is you need to just put the capsule flat on the anterior capsule. Don't try to lift it up. It's not like we are doing with rhexis forceps. So you need to make your capsular flap flat and then just glide it, So it should smoothly glide and change its direction as you are making it, the entire circumference, this thing, 360 degree. Second thing is, whenever you are using cystotome, I've seen beginners, what they do is they try to hold high with the one forceps and use just one hand. So that way it doesn't give stability. So what you should try to do is always support your finger in which you are holding the cystotome with other hand, and so that gives more stability to your cystotome. That's very, I think, a crucial thing which you should remember, that stabilize your hand rather than, the moment you try to hold with the forceps, the OVD tends to leak out from side port and it makes your chamber shallow. So I think, and another thing is, what I believe is, even to a child, if you teach him how to, drive a car, it's very easy. So from beginning also, you should try to learn with forceps and with everything, because it's not only that, your cystotome will work, it won't work in cases where there is increased pressure. So you should try to learn all the shots which are there in the books.
I think
would just
perfect.
like to add one point. Like I have assisted many of my juniors while in doing their second or third cases. What I have noticed is that when they, insert the cystotome or the forceps, I've seen many of them, bending the posterior lip of the wound. So that leads to egress of
Yeah.
entire
Yes.
viscoelastic and it decreases the space. So angulation of the hand so that the pressure lies on the tip of the cystotome and not on the bevel or the bend. So that is something very important, especially for beginners that I have noticed they face difficulty at.
See, that also happens when you're not supporting, no? You're trying to go with one hand, it puts pressure on the posterior lip eventually.
Yes.
So if you are supporting it, it takes off the
Absolutely
pressure
right.
from the posterior lip. Yeah.
Yes, sir.
I think so. I would just like to add one point. Even after 4 years of finishing my PG and 2 years into my private practice, I am not able to do rhexis with cystotome. From beginning only, I was not able to do maximum 4.5 mm I could manage. So to answer Dr. Nikita's question, it is up to you which technique works best in your hand. We have seen surgeon with best of machines and everything, and they use cystotome. They are more comfortable with it. And then beginners like us, we need to invest into Capsulorhexis forceps. What Diksha was telling, exact same points. We have to make sure that the AC is stable with whatever we are using. If AC is stable, then only we can get a complete rhexis. Otherwise, with any instrument, we are going to get runoff and incomplete rhexis. So that's my 2 cents on this.
Thank you, sir. That was a wonderful discussion. Any more doubts from the residents or from the viewers?
I would just like to ask a question to all my seniors here. Like I have read at multiple places using a ND YAG laser to create a nick in intumescent cataracts. So I just wanted to know if anyone has an experience with that here.
See, the principle is same, that what they try to do is to debulk, But
Yeah.
believe me, after 22 years of experience, it can never debulk. See, the amount of the fluid and cortical liquefied matter which is there, I showed, no. We need to debulk from different areas. then only we can decompress the capsular bag. Just one shot, it will never debulk the capsular bag. So I don't think it works in all the cases.
Okay, thank you, sir.
I have one small question for Harshal, sir. So what is your take
Yes,
on
Anuji.
cleaning the anterior capsule? Would you prefer that as residents to practice not staining it as well and doing rhexis, or would you always want surgeons to stain for better precision?
So, Anuji, it depends on what microscope also they are using. If they have access to good microscope, which makes any brown black cataract also looks, give a very good red glow, then they can of course not use stain. But the moment they see that there is a problem in visibility, they should stain it. There is no doubt, especially in cortical cataracts, because those cortical spokes they make visibility very difficult, especially. And another problem is once they lift the capsule, if they disturb the cortical matter down, the visibility becomes very less. So it's always better for beginners to stain the capsule rather than to end up in problems.
And I think the consistency of capsule also changes a lot after staining. If you do not stain, it is very elastic. So like while my transition was there from staining to not staining, I found very difficult to get adjusted to the new elasticity and the new feel. That is also a different learning curve. So it's better to start with staining and don't be too late to convert to doing a rhexis without a stain.
Right. Thank you so much.
Thank you everyone for such a wonderful discussion. So that brings us to the end of the webinar. So before concluding, I would like to ask Dr. Harshal sir and Dr. Nilesh sir for their experience and any suggestions for the webinar.
I think this was a very wonderful and very nice discussion. And Dr. Sandeep, Dr. Diksha, and everybody showed, and Dr. Anuji, they showed wonderful videos. And I'm really very proud of our young ophthalmologist. I don't feel that they have any more, very less in experience. They're really wonderful surgeons. And I wish all the success to them.
Thank you so much, sir.
Thank you so much.
Yes, very well crafted webinar. It was Dr. Lipi and Dr. Anujit, and the discussion also was very to the point. So that makes it a success, I think. With Harshal sir congratulating it, I think it means a lot to us.
No, really, it was wonderful. And thanks, Lipi, for roping me in when Lipi told me that, yes.
We will keep troubling you, sir. We will keep troubling you.
No, of course, anytime.
Sir had a badminton tournament going on. Still, he could.
Yeah, I have to go. We have matches.
Sure, sir. Yeah. Thank you so much, Lipi. Dr. Lipi, I think we can close.
Yes, sir. Thank you so much. Thank you, Harshal sir. Thank you, Nilesh sir, all the speakers. That was a wonderful presentation. And cherry on the top was Harshal sir's expert presentation. I would like to thank all the residents and viewers and team YOSI and all the cataract focus team members also. Thank you so much. Thank you, thank you, Manjula ji, also for managing everything.
Okay.
So
bye, everybody.
Okay, we'll just have a small photo.
Mandatory,
yes.
If everyone can put the YOSI sign. Right. Just give me 3, 2, 1.
Right.
Thank you so much.
Thank you.
Okay. Bye-bye. Good night. Bye.
Good night. Thank you. Good night, everyone. Bye.
Thank you, everyone. Thank you.